Hello everyone. In today's segment of ECG abnormalities, we'll deal with ST segment elevation and Q wave syndrome associated myocardial infarction. What is myocardial infarction? Myocardial infarction refers to myocardial necrosis, or in layman's term, heart attack. So we'll first deal with the anatomy, then we'll deal with blood supply, and then ECG changes. So in the anatomy, we'll see there is an anterior surface which is also called as sternocostal surface. Then there is a diaphragmatic surface which is also called as inferior surface. And then there is posterior surface or the base of the heart. And then there is right and left pulmonary surfaces. So the anterior or the sternocostal surface is majorly formed by right ventricle and some part of right atrium and left ventricle. Then there is diaphragmatic surface or the inferior surface of the heart. It is majorly formed by left ventricle and some part of the right ventricle. Base of the heart, it is formed by left atrium, some part of the right atrium, and the majority of it is from the vessels of the heart. Okay, so we have superior vena cava, we have inferior vena cava, and the pulmonary arteries and the pulmonary veins. The blood supply of the heart. The two main arteries that supply the heart is the left coronary artery, the right coronary artery, and its branches. Circumflex branch of the left coronary artery, left anterior descending or anterior interventricular branch of left coronary artery, then the right marginal branch of the right coronary artery, and posterior interventricular branch of the right coronary artery. In majority of cases, this posterior interventricular branch is given up by the right coronary artery, and that is why it is called as right dominant coronary artery. It supplies the inferior wall of heart or the diaphragmatic wall of the heart. In majority of cases, right coronary artery also supplies the SA node and the AV node. In some cases, it can be done by the left coronary artery. As you can see, the SA node is supplying by the left coronary artery, and posterior interventricular branch is given off by the circumflex branch of the left coronary artery. Okay, then it is called as left dominant coronary artery. So transmural infarction involves the whole part of the heart, okay, the epicardium and the subendocardium. Subendocardial infarction we will deal in next class. First we'll deal with the anterior wall MI. Since it is anterior, the leads that will pick up the ECG abnormalities will be the precordial leads and 1 and AVA. Okay, so in this leads we'll see the ST changes and the reciprocal changes, that is ST depressions in 2, 3 and AVF. You can see the ST depressions here. Okay, so this is an acute phase. What happens in an evolving phase that occurs from hours to days? The leads which initially had ST segment changes will now have T wave inversion. You can see T wave inversion. Okay, and then there is resolving phase in which these leads which initially had these changes, those will regress partially or completely. As we see, there is no ST changes further seen. So this is anterior wall. So if there is an anterior wall, which artery is mostly involved? Left anterior descending. Which leads will be affected? V3, V4 precordial leads. If that is septal involved, more changes we will see in V1 and V2. Again, the artery involved is left anterior descending. If it is lateral or apical, we see more changes of the ST segment in V5 and V6, and it might be either due to circumflex or left anterior descending. In some cases, it can be because of the dominant right coronary artery also, especially in the apical part. If it is high lateral, it can be because of circumflex or the left anterior descending, but the changes will be seen in 1 and AVA. Okay, the variations is You might not see the ST segment elevation. You might only see in the anterior wall. You might see only T wave, tall T waves in precordial leads. Okay, you can see there is no ST segment changes, but there is tall T waves. Okay, but there will be subsequent reciprocal ST segment depressions in foot leads 2, 3, and 3. If you can see, there is ST segment depressions in 2, 3, and 8. So in this variation, ST elevation you might not see, but T wave, tall T waves you can see, and reciprocal ST depressions will be seen. So in inferior wall or diaphragmatic surface, whichever supplies the inferior wall is supplied by posterior interventricular branch, and this might mostly given by right coronary artery because it's right dominant, and in some cases left circumflex artery. So since it is an inferior or diaphragmatic wall, the changes will be seen in 2, 3, and AVL, that is foot leads. Okay, so we can see the ST segment changes elevation, ST elevation in 2, 3, and AVL, and reciprocal changes will be seen in 1, AVL and precordial leads. So you can see ST depression, ST depression, ST depression. Not so visibly seen in V4 and V6. Then in the evolving phase which occurs from hours to days, the initial changes will lead to T wave inversion. T wave inversion. Okay, in the foot leads. And then in the resolving phase, there will be partial or complete regression. As we can see, this partial or complete regression. Posterior wall MI is difficult to observe, okay, because it is in the posterior part of the heart. Anterior can be seen from the precordial leads, inferior from the changes in the foot leads, but posterior wall is difficult to observe. In majority of cases, it mirrors anterior wall MI. So whatever changes you see in anterior wall MI, just reverse it, and you will get the changes in the posterior wall MI. In the right ventricular wall, okay, there is the changes will be seen in V3 and V1. You can see the ST segment in V3 and V1. One thing about posterior wall MI, it is never associated alone. It can be associated with the posterior lateral wall MI or posterior inferior wall MI. So in such cases, you can also choose changes of the lateral, like anterolateral, so posterior lateral wall MIs or posterior inferior wall MI. So earliest sign of the transmural infarction is ST segment elevation, and the ST segment elevation usually persists for hours to days. Okay, and the Q waves just begins to appear at the same time when ST segment elevation is seen. One of the thing is for how long these changes will be persisting. I think as they have mentioned in various books, the ST segment elevations will persist for indefinite period of time. Okay, may persist indefinitely. Similarly, Q waves may persist indefinitely, or they may go off eventually, or may even disappear. Not all transmural infarcts will lead to Q waves, and not all Q waves will lead to transmural necrosis. Okay, normal septal Q wave should be less than 0.04 seconds. So whenever you see a Q wave, okay, so we have to go for differential diagnosis. It is AVR, okay, then the Q waves is normal. Okay. Is it lead V1? Okay, you can see Q waves in such conditions. Q waves is also seen in left bundle branch block, LVH, amyloidosis, chronic lung disease, hypertrophic cardiac myopathy, or dilated cardiac myopathy. So you have to be very vigilant about these things. You have to relate it clinically, okay? Clinically, or with the lab values like cardiac enzymes elevated or not. So you have to be vigilant in such cases. Okay, we have to see one thing: the ECG in a symptomatic patient, okay, may not be a diagnostic of ST segment elevation. Matlab, the patient will have symptoms, but the ECG will not show any ST segment elevation or T wave changes. So in such cases, serial ECG should be done. Things can be reversed also. If the patient is having no symptoms, here the patient was having symptoms, here patient is without a symptom, and the ECG will show changes. So this is called as silent MI. Okay, So in such cases, we should go for cardiac enzymes also. CKMB, TROP-I, TROP-T. These are generally done in ICUs, and if one of these comes to be abnormal and normal, then we can rule out rule in favor of the MIs. This has to also be done serially. It might be initially it might not rise, and so we have to go for serial cardiac enzyme testing. Thank you.